So my paper is on outcome assessment of complications in 147 hemihamate arthroplasties. As we all know, its incidence is increasing because of the ever always injurious cricket ball injuries. And the management is dependent on the fracture configuration as well as the stability. So there are various treatment modalities, especially in relation to dorsal PIP fracture dislocation, which have been described previously. Here, this is mainly done for unstable acute or chronic injuries. So Hastings described this hemihamate way back in 1995, where it was mostly a closely aligned anatomical reconstruction of the joint surface with a matched osteochondral graft taken from the hamate. So the aim of the study was to summarize the complications associated with HHA at a 1-year follow-up. So technique-wise, we used Brunner or a wide volar flap, though now we usually go for the wide volar flap. FDS tendon was linearly split in the midline to facilitate the shotgun approach. Graft was harvested either by transverse or longitudinal incision. Never use sword, always drill holes and osteotomes, and the graft was harvested from distal to proximal. And it was always oversizedly harvested and trimmed on table. Soft tissues were dissected after your osteotomies so that the chance of graft spillage is less. And this graft was nicely carved with a scalpel blade on the table, securely adequate so that it spill out. The concavity of the middle phalanx base was restored and fixed with 2 or 3 1 or 1.3 mm lag screws. And volar plate was repaired back to the collateral remnants. There was no proper collateral ligament repair done. So on the sides, you got 2 stitches for this. The pulley flap was placed under the flexor tendons, and always the joint was gently manipulated to get a passive flexion of 90 degrees on table. If you don't get it, a gentle extensor tenolysis was done through the volar wound or sometimes even through a separate dorsal incision to gain at least 90 degrees of passive flexion. So this is how the malunited fracture after a defect is created and you get it fixed with adequate tilt volarly looks like after 1 year. And coming to the rehab, all patients were immobilized for 2 days. Then from day 3 onwards, they were started on active and active assisted mobilization of both PIP and DIP joints. Terminal extension was restricted. After 3 weeks, a Kapner splint was used to stretch out the residual flexion contracture, which developed over the 3 weeks. And that would be the outcome at the end of approximately 3 months for a hamate graft. So some additional procedures were incorporated, like extensor tenolysis was done either through the same or dorsal approach if you can't get a 90 degrees on table, or in couple of cases I had to do a flexor tenolysis also because getting a shotgun was very difficult because of previous surgeries done. A total of 311 patients were treated over this time period from 2015 to 2024, of which the pylon and the volar dislocations were excluded, and all those underwent open reduction internal fixation or volar plate arthroplasty or fusions were excluded and ended up with 155 patients, of which 8 had no follow-up and 147 was the final number with 1 year of follow-up. Informed consent was taken. All patients were operated by single surgeon and all of them had a 1 year follow-up. So the criteria which were taken, so data which was collected was the gender, the durations injury, the finger predominance, the percentage of articular surface involvement, history of prior massages and prior surgeries was noted, and complications were assessed and the final outcome was measured. So they were broadly divided into intraoperative complications, donor side complications, and outcome at the end of 1 year in terms of the joint movements and adverse events. If we see the incidence of the injuries was much less in the little finger, while ring, middle and index more or less the same kind, more in females, and the mode of injury was the cricket ball in majority of them. Next was the assault or slip or fall and RTA. Time since injuries, it was done even in acute injuries less than 3 weeks in 5 patients, but majority of them fell into the 3 weeks to 6 months category. It was also done after 6 months, and the maximum late presentation was at 8 months. Less than 30% of surface were involved in 11 patients, 30 to 50 in 89 patients, and more than 50% was involved in 47 patients. The history of prior interventions, what was done was 38 were previously splinted, 9 had K-wire fixations, 3 were external block pinning was done, 4 had external fixation, and 16 patients had associated mallet fractures because this had an adverse outcome. The complications which were noted was, the most dreaded was the graft spillage. One patient had a graft spillage on the ground which was washed, soaked in gentamicin and replaced black with no adverse event. Insufficient graft harvest, it was always short, but having 2/3 of surface on either side of the ridges was sufficient for us to get a stable joint. Graft fracture never happened. Fracture of the dorsal cortex was reported in one patient, though it was described during the shotgun approach. This happened when we tried to change the direction of the screw, placing too many holes on the dorsal cortex, which eventually weakened it, and you had a dorsal fracture, which was salvaged with a plate fixation with a not so good clinical outcome. No neurovascular injuries were reported. And follow-up complications, majority of these patients had swelling at the end of 3 months, which resolved by around 6 months, and very few had left over at around 1 year. Residual flexion contracture was of more than 15 degrees was seen, but eventually stretches out with the Kapner splint. Swan neck deformity because of overuse of Kapner was seen in 2. Angular rotational deformities was seen in 11 patients. This was because of the mismatch of the hamate and the proximal phalanx base. Graft resorption was seen in 2 patients. 1 patient had just a screw removal and a good stable joint. 1 patient had a sublux joint and was advised as fusion or a volar plate arthroplasty but didn't turn up. Boutonniere deformity was seen in 1 patient where the ultrasound confirmed a central strip detachment. Again, nothing done as the patient was not convinced about the further procedure. Hardware prominence was seen in 7 patients and 2 had to go for screw removal. Loss of fixation arthritis was nil, no instability. Donor side complications only scar pain and hypertrophic scar. This was the average range of movements on par with other studies and very minimal VAS score that was seen. A large size graft was avoided to be put because more than 3 mm would give a bad overstuffing of the joint. In conclusion, it's a reliable and effective technique for reconstruction of base, giving symptomatic relief, functional restoration, longevity of the joint was restored, nil donor site morbidity, minimal complications, and uniformly reproducible results. Thank you.